Hello for those of you that joined. So we'll give it another 3 minutes for everybody to join, and then we'll start. So. Perhaps another couple of minutes for everybody to join. Just 1 more minute, and then we'll start. Good. So I think we'll start. So thank you all for joining us today at our webinar, A Strategy for Decontamination in Care Homes. And today I'm joined by our Managing Director, Rick Fentiment, and Matthew Airey, the Founding Director of Wessex Care. So this webinar will be split into 3 sections. The first section will give a brief Inivos introduction, followed by the use of technology overview. The second section will include a discussion between Rick, Matthew, and myself. And the third section will include a Q&A session with the audience. So please use the question tab to post any questions throughout the webinar, and we will aim to answer as many of them as we can. You should see the Q&A box at the top somewhere with your controls in, so please post any of the questions you might have during the webinar, and we'll answer them at the end of this, the third session of this webinar. So Inivos is a specialist business focused on the development of technologies and services to reduce the risk of patient-acquired infection in community environments. And our aim is to enable the environment to deliver better care faster. So when we work with our customers, we tend to follow this 3-step approach. First, we understand the infection need within the clinical environment. This is a key step that allows us to use this knowledge to design detailed and practical solutions to best meet that need. And finally, we deliver the results and project manage the process to ensure successful technology implementation. When we speak about the infection in the clinical environment, we often refer to common vectors of transmission. There are 4 main vectors of transmission: surfaces, water, people, and air. So if patients had acquired an infection in the clinical environment, the infection must have come from one of those vectors. And each of those vectors must be understood and addressed when evaluating infection outbreaks and looking at possible solutions. When looking at the challenge that the care homes have faced with the coronavirus, it is known that the typical patient groups are more susceptible to COVID-19 due to their underlying health conditions. And we have seen an increasing trend in hospitals, patients being discharged and sent to care homes to free up bed capacity. So this, combined with close contact of residents, has facilitated transmission of the virus. The figure here shows a widely accepted classification of resistance of various microorganisms to disinfection processes. So this places C. diff spores classified as most resistant to disinfection processes, and envelope viruses placed as the least resistant or most accessible to decontamination processes. This classification is useful to consult when evaluating decontamination technologies, as any efficacy data provided by the technology manufacturer can be practically assessed, and one might know what efficacy can be expected if some specific organism data is not yet available. So our UltraV system uses high-intensity UVC light with rapid decontamination process times, and leaves no residue as it's chemical-free. Our system had been tested to achieve locked-core reduction in CV spores, which, as we've seen in the previous slide, is the most resistant organism to disinfect. Each decontamination cycle is validated with the use of remote UVC light meters called spectrons. These sensors ensure the right dose of UVC light is achieved each time decontamination process is deployed and provides a real-time feedback to the operator. The process is fully automatic with no deactivation time or need to seal the vents or fire alarms, as you would normally do with any chemical vapor or spray systems. So the UltraV system generates UVC light almost exclusively at 254 nanometer wavelength, and that sits outside of the visible UVC light rays. And it's known for being most germicidal and allows for rapid process times. So if you see where the visible light says UVC light spectrum for 2.46 in the ultraviolet phase, where and then uses our UltraV system emits at 2.4 almost exclusively, which allows for rapid process times. So we hold a number of case studies that are available to download on our website that shows how effective UltraV process implementation is. The most interesting I show at the slides here, which is Barnsley Hospital on the right, Royal Pathway. So Barnsley Hospital, the test where we sample the environment, a multiple environment, in multiple places before the cleaning, before the cleaning, after the cleaning, and after the UVC process. And as you can see, there was still a considerable amount of contamination left after the manual cleaning, and then there's virtually nothing after the UVC cycle. In some cases, the contamination actually had increased after the manual cleaning, which suggests that the contamination was spread during the manual cleaning. And with the Royal Pathway, disinfection with UVC UltraV system led to significant reduction in CFUs across all surfaces, but in many cases down to undetectable levels. And these case studies are available to download from our website, and there's many more that we can share to support the validation of efficacy of the UltraV system. So on that note, I'd like to hand over to Matthew Airey and Rick to start the discussion about the work in nursing homes.
Thanks, Talis. That's excellent. Matthew, do you want to just give us a bit of background about you and your facility? I think you've come from an interesting background. It'd be useful to get some more of your insights into this.
Sure, yeah. So my background is I'm by profession a social worker. I then spent 25 years in local authority, finishing at director level about just shy of 20 years ago, when I set up Wessex Care with my wife, who was a consultant nurse at the time. What we have focused on is we're a strategic partner of the local authority and the NHS, almost exclusively in terms of the work that we do, and that ranges from rehabilitation right the way through to high dependency care, end of life care, complex dementia, and mental health care. And most recently, we've set up the hospital discharge support unit. People will know them as COVID hot units, to support our all of the hospitals that feed into Wiltshire in terms of providing COVID positive patients with care, either to wellness or to manage their passing in the best possible way. That's what that's us. That's what I do. My background.
Thank you. And so, just for the sake of clarity, could you just give us a bit of clarity around the difference between nursing care, as your facility specialises in, and residential care, which would a lot of other facilities would be specialised in?
Sure. We have a combination of two, and it's for those of us in the profession, we'll know it's a registration issue. The nursing provision has 24-hour nurses available working in the building, and it is what's referred to as a nurse-led service. So the nurses are in charge of the care planning and the development for that individual. Residential care basically means what it says, and that is it's residential care without nurses in attendance. So they will rely on district nurses to support any nursing need. And there are specialties within that. So for instance, our mental health, our complex dementia health and mental health unit is a residential unit because it doesn't have nurses with it, because it's a social care model of caring for people with those complex needs.
Yeah, that's really helpful. So I suppose what we're seeing in the last few months, especially with especially with the COVID hot centres, is we've seen an increase in the acuity of the patients coming into your type of facility, haven't we? Which is put a different type of pressure on your facility and a different dynamic to the whole care pathway, which I think, from what we've seen of Wessex Care, you've handled extremely well. It's been a very challenging time for everybody, but I think it's going to be a interesting journey from here, really, with the whole acute sector as to how it handles those other care pathways into these what previously would have been known as primary care settings. So I think it's going to be really interesting. So just tell us a bit about UltraV. You were one of the first first care facilities in the UK outside of the acute facilities. As you know, we predominantly have designed and developed the UltraV system for use in hospitals. And you were one of the first nursing care facilities to put the UltraV solution in. And could you just give us a bit of background about your thought process, your decision-making process on that?
Yeah, very much so. I mean, we are very targeted at infection control all of the time, and it's kind of a big public, out there in the public at the moment in terms of the issues with care facilities. But for the vast majority of providers, this is something that they're always very, very strongly focused at. Because of the nature of our partnership with the NHS and the local authority, the level of and complexity of care and also the amount of patients, if you want, that we're dealing with, kind of takes you up to a greater level of risk, really. And so what I was looking for is that we got state-of-the-art systems as far as we were concerned in terms of cleaning products and everything else and how we manage that process, and we have a very good track record for it. But even so, with COVID coming along, this was a kind of huge challenge, and we could see it coming, and so I had been researching for some time systems the hospital type systems and what would happen and what would work. And some of the key elements was, one, it's backed by the evidence, it actually works. Two, it has to work quickly. And three, we have to be able to validate it. We have to be able to say, the fact that we stick a blue light on in a room, that there is something at the end of it that says this actually works and that the science backs it. And out of the research I did, the one that, sounds like a sales pitch, doesn't it? But seriously, the one that really caught me around the validation of it was this particular system, because the other systems I'd seen worked on a timing basis, but you didn't know whether that was sufficient or not. Whereas this one, the way the monitors operate, you absolutely know what area you've completed that piece of decontamination in, and that's what drew me to it.
Yeah, I think that's really interesting, because there's a lot of challenge around UVC light. Particularly, it's attractive for its speed. It's a very fast process, but there's challenge around shadowed areas and the unknowns of that. And I think a lot of facilities have been nervous about that. Could you just talk us through what you've been doing practically on the ground there to try and make sure you're happy with the way that's working?
Sure. Well, your guys provided us with some very good training to begin with in terms of the unit. But what we did was we identified a key individual to project manage it really and use it extensively in our facilities, which are new. Most of them are new state-of-the-art care center type facilities. And what we wanted to do was, because you guys had principally only used it in a hospital environment, to see what was the best way of using it in our environment. And what we found, because it's important to address where the shadows may be and all the rest of it, and to tip the mattresses up, so the room has to be prepared. First of all, you're not deep cleaning. You still have to do the deep cleaning. It's another layer. It takes you to another layer on that. So yeah, so what we have found, to cut a long story short, if you do it correctly in terms of its ability to do areas, pause and move, then we can do a 16 square meter bedroom with ensuite, and we will manage that in about 35 minutes, and it's really fast. It's fantastic. And we've done larger lounges. We actually have calculated that our entire center, which is a 27 bed care center, we could do it top to bottom in under 3 days.
Wow, that's amazing. So just talk to me about the reporting, because I know reporting was quite important to you, and that's a feature of the UltraV system, with the reporting that goes up to the cloud server, and then giving you access to those reports so that you can then use them for your own validation purposes. But do you want to just talk us through how you've utilised that?
I think the key to that is that you know, so we've said the word several times now, but that validation, that proof that it's actually dealt with a particular area, and how it works and seeing it operated once you get skilled at using it, is the ability to set the monitors, the 6 of them in a room, and you set them around the room, and you set the machine in a particular area, and it then, because it's based on the further away the light is, isn't it? The EV, the longer it takes to have an impact. So they literally tell you on this part of the room, you're working up, and it has these little gauges, and it goes right up to 100%. When it hits the 100%, you know that where those 2 monitors are have been dealt with, and you're done. So you can actually pause the machine at that point, step back into the room. So there's no wait for, you know, the chemical dust cloud to settle. You step back into the room, just move it further into a different position in the room, closer to where the other monitors are, hit the button again, outside, sorry, hit the button again. Yeah, you wouldn't want to do it inside. Outside, you hit the button again, and off it goes. And it then knows it's done that area, and it's then learned, it knows that you come closer, and it's doing the other bit. So what you then up do is, with 100% on all 6 monitors, it then says you're done. There's kind of no way of cheating it, and it then automatically talks to the cloud and sets a validation. And I think one of the other things is that we liked was that then you guys are actually looking at that to check that you're happy that it's accurate, that it's doing what it's supposed to do. And that means that we've got an outside validation as well as the operator validating what they're doing on the remote control from the robot.
Yeah, I think that's a really important point. And I know our help desk, our 24/7 help desk, spends a lot of time looking at reports, trying to figure out what's going on, because I think it's we've seen a lot of black art, you might say, or mystique around the whole subject of infection prevention and control. But in reality, it's a very mechanical process. It needs effective disinfection of surfaces and the environment itself to make sure that we're minimising the risk to the next patient. I think the really interesting thing you've been doing there is your proactive plan. You've been doing a proactive program through the unit. Is that correct? And
yeah.
Can you just tell us a bit about that? That'd be excellent.
So we're still developing this because it's quite early days, but it's developing the policies and the procedures. So we're using it obviously on empty bedrooms as they become available as a kind of last thing that we do before they're recommissioned. And the way that we work, we could be having someone leave in the morning, and we'll have someone arriving the day. We'll have multiple admissions a day. So it needs to be. That's why the speed of it needs to be quick, really. But what we're now developing it into is using it in rooms that are occupied, obviously not with the individual in, but finding times when we have patients who have come out of the room, they might have gone for some tests or whatever, and then taking that opportunity to obviously clean the room as we would normally have done, but then blasting it again, but also then doing kind of corridor areas, and we've got as far as doing full corridor areas, and then other spa areas or whatever else. We're looking at offices, you know, where the staff are sitting down taking notes and doing all that, you know, having them, when they're not in a busy period, being able to be very proactive and going in straight away and just, you know, decontaminating those kind of areas. So that part of it and that development is well on now. And the next phase is to take it into our complex dementia and mental health unit, because that's a serious area of risk in terms of contamination.
Yeah, I think that's very interesting. I think the proactive plan is always something we found very positively received in the acute sector, because I think what we've seen come out of this whole COVID crisis is the subject of asymptomatic spreading.
Sure.
It was previously not a very well documented subject, but it's been sort of headline news in the last few weeks. And I think what we're seeing is patients that you wouldn't previously have associated with being contaminated, being infectious or spreading contamination. There's an unknown quantity there, and it's something that a lot of facilities are now looking at themselves and saying, what can we do to reduce the risk of that asymptomatic spread, and how's that going to impact you know, our long-term reduction and management of infection. You mentioned earlier on our call earlier about the reputational value of what you're doing as your organisation, which I think just from looking at Wessex Care, I think we've been really impressed with that, the value you're putting on your reputation. I think as the healthcare models are changing, and who knows how that will pan out in the UK, how do you see this panning out for you as adding value to your reputation?
I think how we answer the challenge of infection control will make or break what we do fundamentally. You know, if I'm thinking about having someone cared for in a residential unit, you know, my mother or whatever else, you know, as a member of the public, I'm going to want to know that people are being professional about what they're doing, but are using, you know, every validated processes to ensure that we are as clean and as safe as we need to be. So, you know, we work in a local community. We work in South Wiltshire. We're very known in South Wiltshire. And therefore, you know, looking around all the time for what more can we do? What's the next level? How do we tackle this? And it has to be tackled on the basis that everybody's got COVID-19.
Yes.
You know, it has to be everybody we care for, because, you know, this notion of asymptomatic is a real challenge, because, you know, it started with a temperature and, you know, a temperature spike and a cough. In older people, that's not how it presents generally.
Yeah.
Generally, they present as they would do when they're high-level dependency care. It's how they generally present. And we have tested significantly. We've been very lucky that we've been able to do that across our staff and our residents, and we are, and we've managed a small outbreak as well, so we have that experience. But I couldn't tell you the difference.
It's amazing, isn't it? And I think that's the real challenge we're seeing now, is that a purely responsive mechanism or responsive approach to infection prevention and control in our facilities, whether we're acute or in primary or whatever facility we're in, is not enough anymore. And I think the whole proactive approach is definitely something that we're seeing come to the fore. Is it fair to draw you just on the point of funding? I think you've got some funding support with this. Whatever our political leanings are, that we were glad of the government's support by way of funding for the care home. I think they announced a £600 million fund of some description, which we found a lot of care facilities struggling to get hold of that. But I'd be really glad, Matthew, if you could just give us your insights into how you went about that.
Sure. But, you know, my insights have to be Wiltshire based. Although I'm a national director for the RNHA, you know, and I do see the bigger picture. But I think locally, we've worked very closely with the CCG and the council in order to address this. So there's been basically two sets of funds and a third one for me, because I have a hospital discharge support unit. And what I was able to do was to talk to the commissioning directors and say, look, the whole focus here is on infection control. Thank you for the funds in terms of PPE and stuff like that. That's, for us, has been great and very helpful. And for covering a lot of other things, but actually, we want to go to this level. We want to, take this to another level. So, approach them on a third basis, and to say, look, I'm not asking you to pay for the whole thing, but I'm asking you to partnership us in developing this into care homes, and maybe we can use it as a springboard to support our other colleagues in the sector in terms of finding the funds for this. So how is it being funded? Well, it's fundamentally being funded from the first tranche of COVID funds that came through. So this is the council lot, so that's before the 600 million. The other third is being funded by the CCG from their funds, and that was a request. And the other third I'm funding. And I will use part of my 600 million to do this, and probably to buy the second unit, which I'm hoping to do when our new care centre opens. All of that is possible. The problem was with the 600 million was that it had very defined parameters in which you could spend it. And I'm happy to pass on information to any. That's broadened significantly now. The key thing is getting the agreement with your local authority. And one of the things, for instance, Essex have done and agreed, and it's now been agreed here in Wiltshire, is they call them fogging machines. Now, which is fine. The moment that I knew I could fund this machine from that, because they are about infection control.
Yes.
And it's in the spirit of that 600 million. So people can, I would argue, and I think we can provide evidence, use those funds to support the purchase of this type of equipment.
Yeah, that's really helpful, because I think there was very, as in a lot of these situations in the face of a global pandemic, there was a lack of clarity around what this money was actually for. Although everybody was glad to see it coming, it was a bit questionable as to what it was actually for. So I think that's really helpful feedback. You know, we were glad to see you successful at that, and we can happily provide more assistance for any of the listeners on that point. Tautis, I don't know if there's any other questions from you. Have you got any questions?
No, I was really pleased to hear from Matthew about the fact that, you know, you've obviously took advantage of the validation of the process. Really happy to hear that you got the training and you know how to deploy these spectrums to make sure you do get the right dose of UVC light. And then you do use the reports that these systems generate to kind of keep your audit trail. So it's really good news. There's quite a few questions in the Q&A. Perhaps we can look at that.
I just want to clarify something. I was just saying about the funding, because it's important I get this right. So the CCG funding was a direct result of the fact that we set up a hospital discharge support unit.
I see.
Okay, so I just need to clarify that, because it will not be easy for you to go in automatically. It shouldn't stop you asking, but the reason that I got it was because we were operating a hospital discharge support unit, and it's just to be clear about that point. But the other funds, yeah, absolutely, you can apply through those other funds.
Yeah, I think that's one thing I wanted to highlight about your setup is you have a slightly unique arrangement with that hospital discharge facility, don't you? Excellent.
Yes, we are managing patients that we know have COVID or is highly suspected of having COVID-19. Yeah.
Yeah, and typically would be still in hospital in normal times.
Yeah.
That's very helpful. Tautis, do you want to go through some of these questions?
Yes, so there's quite a few questions. So I'll start with the first one. So there's a question about the fact that in terms of disinfection coverage in the room, somebody would like to understand the comparison between the efficacy of UV and fogging.
Kick that off, Tautis, and then we can. I'll hand back to you, because you can answer the more technical approach. But I think from that perspective, we've seen our roots go back to hydrogen peroxide vapor, and it's an excellent technology. It works very well. It's particularly effective against against the endospore organisms, particularly the Clostridium difficile, which is difficult to kill with other traditional disinfection methods. But hydrogen peroxide vapor is a very effective way of doing it. Its challenges are that it takes longer. The residue, so you've got to get rid of the residue of hydrogen peroxide vapor at the end to make it safe for you to readmit patients and to reoccupy the space. Arguably, it has a better coverage than UVC light, but we're finding in most situations when you have proper training and proper management of the system, where you've got people using it for the right reasons, that UVC light can be a very effective alternative to hydrogen peroxide vapor, and it has a lot of upside in the form of downtime and no residual at the end of the cycle. But do you have anything else on that, Tautis?
Yeah, and I think it's important to draw the distinction between, although we talk about hydrogen peroxide vapor, which effectively would break down to oxygen and water, although it take longer, there's some other fogging methods that, perhaps would use a different chemical. So the UVC light is residue-free and chemical-free, so that's one advantage. And clearly going the right, SOPs and making sure the process is automatic obviously helps. However, with the UVC light, with the UltraV system and the spectrum technology, you do get a high level of efficacy in the shortest process time, as you just mentioned. So we need to make sure we use the right technology at the right time. And I guess the UVC light technology in this particular instance was the right choice.
I think it's a really good point you just made, because I should have emphasised the point that fogging, not all fogging is equal. That we've seen a massive increase in what we would commonly know as spray and pray systems in the last few weeks and months over the COVID crisis, where there's a kind of a placebo effect to spraying a bunch of chemical into the room and hoping it's doing something for us. In reality, it's very questionable science behind it as to whether it's an effective way disinfecting or decontaminating a space. So it's really important to, I think what Matthew's emphasised earlier is just to understand the science behind what we're implementing. It's not a question of just spraying chemicals into the environment. I think you said earlier, Tautis, about not replicating or not replacing one risk with another.
That's correct. That's correct. And I would definitely ask the questions about, what is the process, what chemicals we employ, what do you have any case studies, so that the company that would provide the service should absolutely understand their technology and their SOPs and what they do. If they can't, well, I think we should probably consider that the chemicals used aren't exactly the right ones for the job. So
good. Matthew, do you have any comment on that?
Yeah, I did a regulatory one. You've got to expect that CQC, who are going to be coming back in, are going to be really focused on infection control. And if you've got a piece of kit and you wave it at them and say, look what I've done, they're going to say, where's the evidence?
I think that's very good. And I think we work with the health and safety executive closely on a number of new product development projects we're working on, and it's obvious, I think, from observation that they've got a special focus on some outlandish claims that are being made around some of the disinfectants that are being sort of appeared in the marketplace. And I think it's really important that as care providers that we're extra vigilant in our selection of what we're doing.
I think the other bit that struck me, I didn't say this earlier on, but was in terms of the risk assessment for the people that are actually using the system. And in the time of that, so, one of the, I thought with the the chemical-based systems, it kind of just worries me about, I've got to store them somewhere, they've got to be safe, the person's got to be, have special kit on, all of that, and all of that adds to the potential risk for something happening. I can see that being managed in a hospital environment and all the rest of it. But in the care environment, we needed something which was much simpler than that, and to operate much safer, really.
Yeah, it's a very valid point. Yeah.
Good. If we can move on, there's another question, and although we've touched on that point, but the question is there any training needed for the UltraV system? And the answer is yes, and perhaps Matthew could comment on your experience with the training that you've received for the UltraV.
Yeah, and I actually did the training. So it's a very detailed training in terms of technically how it works and how you operate it. It's based on you have your own ID card for the machine, and it will not operate without that. And you cannot get that unless you've done the training. And that was a process we really liked. So, as long as you've got you've got your own internal processes working properly, that the person is validated to do that training. I have to say the training is really simple and straightforward, which I was mightily glad about. When you look at it, it looks like a fantastic, complicated piece of kit, but it's actually very simple to use. And the independent unit that you operate out of the room, obviously, is kind of like an idiot's guide to what you're doing. I find it very simple and straightforward.
That's good, thank you. I think we've put a lot of emphasis on training, haven't we, Tautis? And we've invested heavily in making sure that the technology itself there's a very fine balance when you come to designing technology, that it's effective, it works, but also that it's simple to use. We can't have, unfortunately, we're not employing rocket scientists to operate this equipment, so we have to have it simple to use. And I think that's something we've worked hard on.
Well, I'm definitely not a rocket scientist, but I was able to use it.
Oh, you're nearly there, Matthew. I can.
Just to summarize, so every training session would include you watching the full training video, how to deploy the system. Then everybody would undergo a practical assessment and then answer a quiz. And then they would see, the trainer would show how to use the system. You'd go through all the steps, and then you'd get a short quiz where you can demonstrate your knowledge of how to use the system. Plus, you get your card, as Matthew just mentioned, then which is obviously only controlled by you. So you can't, nobody else can start the system without that card. So good. We have another question. It's an interesting one, saying that I'm from a hospice in Scotland. Is the system approved for use in NHS Scotland? And is there funding in UK available for hospices which are independent sector?
Shall I take that one to start with? So the as far as Scotland is concerned, and the approval of the product in use in Scotland, yes, and we've got a number of hospitals in Scotland already using the equipment. And as far as the nursing home or the nursing care funding is concerned, through the government funding, the 600 million, I'm not quite sure how far north of the border that stretched, that funding pot, but I'm sure we could come back to you separately on that to give you a more detailed answer on that point. And happy to support in any way we can to give you the information you need to satisfy your local funding route. I think the important point about hospices, we specifically have an interest in hospices. It's a personal interest of my own, and we're doing a separate funding support program for hospices. So if you are a hospice that qualifies for our support program, we'd be glad to do what we can to support you. We have some free of charge services which we provide to hospices, just out of a personal interest of my own and of the business. And so I think we'll get someone to follow up with you after the session to make sure that you get the information you need. But very definitely it is validated for Scotland, and I'm sure we can find a way of working with you. Tautus, have you got any more to add on that?
Yeah, just a follow-on question is that, are we able to share which hospitals in Scotland use the system?
Yeah, by all means. I'm pretty sure the Glasgow Royal Infirmary, we definitely do the hydrogen peroxide vapor there. I'm pretty sure we're making some progress with UVC Light, and also in Inverness. Sorry, my memory shouldn't slip my memory, but Inverness is a very avid user of the UVC Light system. And we use it a lot there on a proactive and a reactive basis.
Excellent, thanks, Rick. There's one more question about what is the expected life of the device, and Rick, perhaps you can comment on the SLAs and what kind of, how we support our customers when they invest into the technology.
Yeah, thank you. So the technology was launched roughly 5-6 years ago. Is that right, Tautus? Between 5 and 6 years ago.
Yeah.
And so we've not seen any of the units come to the end of their life yet. So I would expect them to be sort of a 10 to 15 year lifespan, I would think, at the current rate of what we've seen in the marketplace. I think obviously a lot of that depends on how they're maintained. We offer a service level agreement which includes maintenance, the routine maintenance of the machine, additional training, and any repair support of the device in its life. And I think we've seen some hospitals using these devices kind of pretty heavily, and the machines themselves standing up to that wear and tear quite well. So not experiencing any life cycle issues that we know of. Have you got any other comment on that, Tautus?
Yeah, so definitely speaking, the lamps that we employ are rated for, I think it's about 9,000 hours. So that kind of equates to about 27,000 processes, depending clearly on how many processes we do. So, but we do support these systems, and they get regular software updates, and so yeah, they keep on performing as they are. Plus, because we use spectrum technology, any UVC light, any of the aging of the lamps would be fixed by the fact that the system would just stay longer on, just to make sure we get the right dose. So.
I think it's a really valid point that if the spectrums detect a depletion in the UVC output, they will compensate by running the process for longer. And that answers the next question really, is the expected life cycle of the tubes, of the UVC light tubes, is 27,000 processes. Is that what you said, Tautus?
Yeah, so it's about 9,000 hours. So when you kind of look into how many processes it can do, it'd be about 27,000 processes. So that's quite a few.
We would obviously proactively change the UVC light bulbs on a proactive service. So we would never, I don't think you'd ever expect to run the bulbs till they run out of their useful life.
And then just on the back of that, so if one of the bulbs get broken or damaged or stop working, clearly the spectrums would account for that and keep the system going. So as an example, other systems perhaps would just continue with their set cycle time, which clearly if you have 1 out of 4 or 5 bulbs off, would obviously give you a different result. So the spectrum technology definitely ensures that you get the right level of efficacy, kind of looking into the depletion of the light or how many lamps you actually have working. So
I think that's really useful. And I think also we've seen kind of some novelty come around with the use of robotics on UVC lights, and that's something that's interesting development, but it doesn't remove the need for monitoring, because if we don't monitor, there's no way of regulating what the UVC light output is and what level of efficacy we're achieving. So Do you want to just talk us through the validation, Taz? I just noticed a question there about validation, and I don't want to bore everybody with science, but I think it's something you're very passionate about. So I'd be glad of your feedback on that.
Yeah, that's correct. So as engineers, we clearly can't wait for the results. And we wanted to make sure that when you deploy the system, you get your results straight away. And we had to come up with a way of making sure that we know the light works in the dose. So we need to make sure we expose that surface to the right amount of light to get the right amount of dose. So when we did our test with UltraV to get the log reduction, we'd make sure that that amount of dose is logged. And then the further away you position the spectrums, it would just prolong the cycle. So each time you deploy the UltraV and deploy the spectrums, you essentially get the same cycle that we got at when we tested our systems to achieve that log4 reduction on C. diff spores and then log5 reduction in bacteria. So every single time you deploy the system, you essentially repeat the cycle that we validated to make sure you get the same level of efficacy every single time. If you don't, you get a message with thumbs down. The system will time out, and there's no ambiguity about the fact whether they were successful or not. And the system will send a report to say the process was unsuccessful. Even if 5 out of 6 spectrums got thumbs up, we're not going to tell you that it's been done, and you'll be able to make the right decision to go and repeat the cycle. And that's the whole beauty that we position the operator in front of the control of what's actually happening, so there's no ambiguity about what happens in the room, when it's safe to re-enter, etc.
That's brilliant. Matthew, have you got any comments on that?
No, yes, in the sense that is exactly why I chose the system, really, and certainly when we did the training, that was very clear. You can make it will come up with an error if you've done it wrong. You'll know, and in fact you can almost see yourself doing it wrong on the system. If you and we've tried to see, can you hurry it up, can you do this, can you do with that, and it knows exactly what it's doing in that room, and it's then validating that, and it's sending it off independently to you guys, who can say, no, that's not right, or that's not working, and whatever. And that's fundamentally different from putting a piece of kit in a room and switching it on.
Yeah, no, I think that's a really valid point.
Yeah, I think it's a game changer.
Yeah, and I think there's a real pressure for making things robotic, and we're fundamentally, this is a robotic process that we're applying here, but it's so important that we've got some calibration back to make sure that it is actually achieving the right level of output as a device. There's one question here about how much does it cost? Well, that's straight to the point. We typically, these devices are selling into the acute healthcare sector at £33,000, and that's the kind of price point for these devices. I hope that ties up with what you paid, Matthew.
I'll have to check that. It was around about that. Yeah.
Excellent. Good. Well, thank you, everybody. I don't think we've got any. Oh, sorry. There's a question here about availability. So the machines are produced in the UK. Our supply chain is in the UK. We produce and manufacture these devices here. So it's all very controlled and very sustainable in the UK. And I think that's the way we intend to keep it, because of the way the supply chain has moved in the last few months. And we've got these devices coming off production line every day. So there's no shortage of supply right at the moment. And we've managed to keep up with demand right the way through COVID. So we're very pleased with that. Any other comments, Tautis, before we close?
I think that will finish off the question section. So,
Matthew, has you got any other points to make before we close the session?
Nope.
Well, I'd like to thank you, Matthew, firstly, for all your time and your support. I think it's been really fun working with you, and I hope we can work with you again soon. And anybody that's been on the call that would like to work with us, we enjoy this. This is the fun part of our job. So please reach out. We love working with real care providers doing real work. That's the fun part of what we do. So I don't think I've got anything else to add, Tautis, and thanks for hosting.
thank you all.
Thank you.